Good morning. We are now on the record for the non-stenographic video deposition of Dr. Gary Vilke. The time is 10:39 a.m. Today's date is June 29th, 2021. This is a case of Shawana Phillip versus Harris County. Case number 418-CV-01586. My name is Mario Ruben Villarreal IV, and I'm a notary public with the state of Texas and the deposition officer for today's deposition. Objections by the rules?
Yes. Form is sufficient.
Are there any stipulations to put on the record?
I think we probably need to agree on the remaining time, which is 3 hours and 53 minutes remaining on the record, not, I guess, including the moment we started here introducing. And that's based on the continuing deposition of Mr. Vilke from 2 weeks ago, on I think the 21st.
Actually, isn't it, we've used 3 hours and 53 minutes?
Yeah.
So we have just a little over 3 hours to go.
Yes. Whatever the difference is, I get, what is that, 3 hours and 7 minutes.
Okay.
Not including this time now.
Right.
And the only other agreement is that if Ms. Bradley objects for one defendant, that covers all defendants. And vice versa, if I object, it covers her client.
Yes.
Okay. Would all counsel please state your name and state your appearance in this matter?
UA Lewis for the plaintiffs, estate of Donovan Phillip et al.
This is Suzanne Bradley and Rachel Frazier for Harris County.
Jennifer
And
Cowan.
just, if I can quickly correct, it's F-R-A-S-E-R is the spelling of my last name. I keep seeing it's misspelled. It's F-R-A-S-E-R. Thank you.
Jennifer Callan for defendant Rita Okoji.
Will the witness please state your name and spell it out for the record?
Gary Michael Vilke, V as in Victor, I-L-K-E.
Are you alone in the room you're in, or is someone else with you?
I am alone.
Okay. Will the witness please raise your right hand? Do you solemnly swear and affirm that the testimony in this matter will be the truth, the whole truth, and nothing but the truth?
I do.
You may proceed.
Okay. Good morning, Dr. Vilke. I don't know if I've actually never continued a deposition, so I don't know if you have or not, but I think that we'll just pick up where we kind of left off last time, but I'm going to just ask some of the same questions because I think just in case things have changed from our last deposition, I just want to make sure I cover that base. Now, you're required to advise of all the medical literature that you have reviewed and relied on in this case to form your medical opinion. Have you, now, before you've disclosed some of the information that you have relied on, and you said that you didn't rely on any medical literature or reports or publications, is that correct?
Nothing specific. I didn't look up or refer to any specifically for this case. Obviously, my knowledge based on the materials I've read of my career experience, my training, but yes.
Okay. And so that answer remains the same, correct?
Correct.
Okay. And have you reviewed any documents or materials related to this case that you did not list on your report that we talked about last time that you may have reviewed in between time from the last deposition until now?
Yes, no new materials in between the deposition.
Okay. All right. And have you reviewed your prior testimony?
I have not.
Okay. And so have you watched the video deposition of your prior testimony at all?
I have not.
Okay. Do you want to change or clarify anything from your previous testimony?
I haven't reviewed anything to try and clarify, so I don't know what I would clarify at this time without having seen it.
Okay, but you were obviously there. So in reflection of your prior testimony, is there anything that you can think of now from your prior testimony that you want to clarify or change?
I gave my best testimony at the time. I don't recall anything that I would want to have changed, otherwise I would have probably done it at that time.
Okay. All right. And since our last deposition, have you visited the jail at all?
I have not.
Have you spoke to any witnesses, any of the defendants or individuals that work for the jail? Well, you know, I'm sorry, that's compound. Let me, have you spoke with any of the witnesses at all?
I have not.
Okay. What about, have you talked to any of the employees that work at the jail or any of the medical staff?
I have not.
Okay. Okay. Now, in your CV, you stated that you were the medical director for the San Diego Sheriff's Office, but that was not directly with the jail itself, right? It was through UCSD?
Right. I was the director for custody services for UCSD and liaisoning with the Sheriff's Department.
Okay. Who was the sheriff when you were, you're no longer in that position, is that right?
That is correct.
Okay. Who was the sheriff while you were in your position as, sorry, when you were in the position of custodial director or custodial?
I believe there was two. The last sheriff, there was Gore, Sheriff Gore.
Okay. And were there any other sheriffs?
I believe when we started in 1999, there was another sheriff there, and I'm not recalling his name, but yeah, I think they switched somewhere between the time I was there.
And that was when you first started though, right?
Correct.
Mm-hmm. Do you know why the contract ended with UCSD?
As I understood, they were going to change for outsourcing the services to another provider.
Okay. Was UCSD not considered an outsourced medical provider?
We were at the time. Yeah, we were basically contracted to provide on-site medical care at the sheriff's facilities, as well as take care of patients in the hospital.
Okay. And you were there from 1999 until 2016, correct?
That sounds about right, yes.
Now, during that time that you were there, the San Diego jail was considered the deadliest county jail in California. Is that correct?
Objective form.
Not to my knowledge, no.
Isn't it true, according to the statistics, that the rate of inmates' deaths in San Diego County exceeded all other large counties in California during the time that you were the director of custodial services for UCSD at the San Diego County?
Objective form.
Not to my knowledge, no.
Okay. Okay. And isn't it true that the rate of suicides were their highest between 1999 and 2008 while you were the director of jail custodial services?
Objective form.
Sorry, the custody services.
I was the UCSD Director of Custody Services. I was not the jail's medical director. That was a different position under the Sheriff's Department.
Okay.
And again, not to my knowledge, to answer your question.
Okay. Do you keep up with those statistics?
I do not.
No.
I do not keep up with the statistics because my job is to take care of patients at the jail, not to run the full 24-hour medical services that are done by the Sheriff's medical director.
Okay. So are you pointing that out to distance yourself from the statistics of San Diego County jails being the deadliest county of the larger counties in San Diego? Oh, excuse me, in California?
Objective form.
I was pointing that.
I just want to make sure why you're making it clear that you're not the medical director, and your job is it to distance yourself from those statistics that indicate that San Diego was the deadliest, San Diego County Jail was the deadliest jail and far exceeds the other large California counties during that
Object-
period, 1999 through 2008?
Object to form.
I was pointing that out because you were asking me questions about statistics that would not be under my purview. That would be the medical director for the sheriff's department to understand. My job would not be to follow statistics on the full jail system because I did medical. I didn't do psychiatry. I didn't do the nursing. I didn't do the custodial aspects of it. So that's why I was pointing it out, that it would be the medical director's role to know numbers, not necessarily mine.
Okay, so you were responsible under your position for the medical care and not the psychiatry at the jail, is that right?
Correct. Psychiatry was outsourced to a different group, as is nursing is under the contract of the sheriff's department. So we had the physicians that did medical care only.
Okay. And what about the, would you say that you would be, that you were responsible for the deaths that were a result of delay and denial of medical care in the jail?
Object to form.
I would not consider myself responsible for those, no.
Okay. And I understand you wouldn't be you wouldn't say that you're responsible for deaths, but I should say the care of inmates during the time of the alleged delays and denial of medical care.
Object to form.
We provided care. If there were delays, it would not be on behalf of the medical group. If there were delays in approving things or delays on the psychiatry side or things like that, that would not be under my supervision. I don't know. I know that there were some suicides during that time that would be not under my group. So the references you're having, I'm not familiar with all the details of it. But as far as the care goes, we provided the care as requested.
Okay. Thank you for that clarification. And have you provided testimony in any cases involving deaths in San Diego? I know we kind of touched on that before, but I want to ask specifically to any relating to medical care.
I believe I had testified in a case regarding a response to a man down in the jail. I think so. Yeah.
Okay. And can you give us a little details about your testimony in that case? Is it true that you found that there was nothing wrong with the treatment in relation to that man down in the San Diego County Jail?
Object to form.
I don't remember the details, but I believe my testimony would have been something along the lines of there was not a deviation from the standard of practice.
Okay. Have you ever found in any of your testimony at any time when providing expert testimony for cases involving jail medical that there has been a deviation from the standard of care?
I know I've been involved in cases in which there was, I've opined that there's deviation from standard of care. I don't recall if testimony was actually given, if it was just a report that was used to settle the case.
Okay, so one time?
I think at least twice.
Okay. And we're not talking law enforcement. I'm talking specifically jail.
That's what I was answering for, yes.
Okay. All right. And what about outside of the jail? Have you ever found that law enforcement has deviated from the standard of care outside of the jail?
Object to form.
Law enforcement doesn't do care, so I wouldn't have opined on standard of care for a law enforcement officer. That would, I guess, be a police practices expert.
Okay. So it's your testimony that a law enforcement can't deny or delay medical care outside of the jail?
Objective form.
If you're asking about medical care provided by a law enforcement officer, if you mean in response to that, I guess they could provide first aid or something along those lines. I don't believe I have found that they have deviated from the standard of what would be their level of training.
Okay, but you haven't been asked though either, right? Is that why?
I don't think so. I may have been asked about a response to CPR or something along those lines in a field scenario where there's a person down, but I don't remember specifically.
Okay. Do you remember, or do you know how much work you've done on this case so far?
Objective form.
I don't.
Okay, no
Yeah, I
problem.
looked it up last time for last deposition, but I don't
Okay.
remember.
I just didn't
remember
want to forget to ask that question. It was kind of out of, I put marks so I didn't want to forget to ask. Okay, and now, okay, now in your previous testimony, you testified that your expert testimony has never been limited or excluded from a court. Does that remain true? Have you testified since our last deposition? Or a ruling on your ability to testify as an expert?
Right. I think I clarified your question last time, and I stated that there are parts of testimony that are sometimes limited as part of court proceedings, where they will have duplicate experts or areas that aren't allowed to be discussed. Certain things can't be brought up. For example, if somebody's on methamphetamine and the judge rules that the topic of methamphetamine cannot come up in court, that would obviously limit my testimony in that area. But I've not been excluded from participating in a trial or court case based on the ability of not being deemed an expert.
Okay, and that includes the period from our last deposition till now, correct?
I think there was a trial, maybe two. It was right. Actually, I think it was the day before your last deposition with me, in which the court had ruled that nobody could talk about the person being high on methamphetamine, and so that limits my discussion on the concept of methamphetamine. But I was able to testify for the other aspects of my opinions.
Okay, and do you know why the judge limited your testimony on methamphetamine? Is it because, well, I'll let you explain that.
Objective form.
He limited everybody's testimony on methamphetamine, meaning that nobody could bring up the concept of methamphetamine intoxication in the individual.
Okay.
And my understanding was that there was concerns that it might be biasing the jury. So that's all I can give you, but it wasn't limiting me specifically. It was eliminating a limitation of the entire court case.
So nobody could talk about methamphetamine, correct?
Correct.
Okay, and what was the name of that case?
Donna Storg versus, I think it's Ontario.
Donna Stark?
Donastorg, I believe is how it's spelled.
Okay. And was that a trial or was that a deposition?
That was a trial I was referring to.
Okay, and how did that trial conclude?
I have not heard of the results of it yet.
Do you normally hear about the results?
Sometimes people let me know, sometimes they don't. Sometimes I look up, see if it's in the Google or reach out sometime down the road, but I guess I don't always.
Okay. Were you challenged at trial based on your testimony?
Objective form.
I'm not sure what you mean by challenged. I was cross-examined, if that's what you mean, but my testimony was not limited beyond what I explained. The court's limiting the entire.
Okay. Okay. So they didn't re-urge it at trial. In other words, your the motion to strike you as an expert or your topics, correct?
Objective form.
Yeah, I wasn't stricken as an expert. I'm trying to be clear. The topic of methamphetamine was not to be discussed by any of the police practices experts, the plaintiffs experts, me, the medical examiner, anybody else performing it. So it wasn't strict. It was just a limitation of what could be discussed at trial.
Okay, and that's my understanding. Thank you for clarifying that. Dr. Vilke, have you I know we kind of touched on this, but I just want to be clear. You have not reviewed any other reports from any other experts in this case, correct? I mean, our last deposition, I'm sorry.
Yeah, I reviewed nothing new since my last deposition, correct,
All right.
in this case.
Okay, and so that that includes from when we last discussed the 2009 DOJ report that found that Harris County violated inmates' constitutional rights related to medical care, specifically chronic care. You have not read anything related to that DOJ report, correct?
Objective form.
That is correct. No new material.
Okay, and did you review the depositions of, I want to, maybe I have it here. The deposition of Dr. Sandar.
I did review that deposition, yes.
Okay. And you also reviewed the deposition of Dr. Geis, is that right?
That is correct.
Okay. Okay. And in review of their deposition, do you recall the testimony regarding the 2009 DOJ report?
Objective form.
I do not specifically recall that now.
Okay. And a part of that report, excuse me, a part of that testimony in the deposition included the fact that there was no training meetings or policies that were instituted as a result of the report. And you didn't notice that in the deposition, excuse me, in the deposition testimony either, correct?
Objective form.
I don't recall that specifically.
Okay. And in the deposition, the medical director indicated that he was not aware of the DOJ report, just like you. You didn't notice that either, correct?
Objective form.
I'm not sure which medical director you're referring to, and I'm not sure what you're referring to me knowing about either.
Okay. Okay, and Dr. Geis, excuse me, I'm sorry, Dr. Vilk, we talked about some of the other things that you did not review in your report from our last deposition, and that included the custodial death report, the depositions of the officers, Baker, Wastel, Rodriguez, Harrison, the inmate statements, the statement from Shawana Phillip, the statement from nurse, or the statements from nurse Carrie Rosa, the statement from the physician assistant Meredith Thomas, the statement from the witnesses that were inmates in the pod that Mr. Phillip was in at the time that the jailers came and removed him from the cell. And the or any videos, correct?
Objective form.
Does that remain the case?
If that's what I said, I didn't have my deposition to review, but if that's what I said last time and I didn't review them, I have not reviewed them since then.
Okay. Do you intend on reviewing?
You guys, can I take, I'm so sorry, before our next question, I need just a 5-minute break. I
I
apologize.
already asked my next question.
No, you were in the middle of it and I interrupted you. I'd like to take a 5-minute break. Something emergency just came up. I want to listen to this deposition. I am kindly asking to take.
Okay, I want this time back that she's talking.
Oh, come on. We're not doing that all day yesterday.
I want
Miss-
the time back.
Miss
I'm not,
Lewis,
listen, I'm gonna give you a break.
Rachel, and you wait.
Time back.
Take your break. You wait, I'll give you 5 minutes back. At the end of the day, it's
Thank
fine.
you.
Let's take a
Okay.
5-minute break.
The time is 11:05 a.m. and we are now off the record. The time is 11:11 a.m. We are back on the record.
Okay, Dr. Vilke, we left off on going through the materials that were available, but you did not review in formulating your report. And I was asking you whether, well, let me ask you another question. Do you agree that in formulating your opinion as an expert, your report is only as good as the information that you're provided?
Objective form.
It's based on the materials I review, and then my background and experience and training. But if there's more materials to review that have different differences or something like that, it certainly can. It's worth having more information, sure.
Okay. So do you intend on reviewing the information that was available but not provided to you after this deposition?
Objective form.
If provided to me, I review materials that are provided to me.
Okay, but do you intend on requesting the information that was available but not provided to you from the list that I went down just a moment ago, and revising your opinion or your report?
Objective form.
Again, if in discussion with counsel, if they want me to review it, I will review it. Obviously, if there's any changes based on that material, you would be made aware of that. But at this point, I don't have specific plans unless provided to us.
Okay, but you don't intend on seeking that information yourself, only if they provide it to you, correct?
Objective form.
I would discuss with them, and if they think there's materials that I should review, I will review them.
You think that if there are materials that you should review, that you would in fact review, if it were available before your report, that you should have been provided those particular items?
Objective form.
In cases, there are lots of materials that are provided to review. I've received quite a number of materials in this case as well. Sounds like there's some other materials out there that I can certainly review, and if provided, I will review them. And if they're impactful on my opinions, then obviously that would be important to know. And so, as far as the obtaining them, I don't know what all is available. I know certain things are based on your list there, it sounds like. And I would discuss with counsel about reviewing them.
Okay. And according to all the items that I've outlined in my list, if they were available before you completed your report and you read them after this deposition, and they could have been provided before you completed your report or even this deposition, should you have been provided that information so that you can formulate your report or participate in this deposition?
I'm going to object to asked and answered. Objective form.
Again, they provide me the materials. I don't know. It's not like a pick list that I want certain things, I don't want certain things. They provide materials to me and I review them. So, if there is more material out there to review, again, I will, now that I'm aware of that, I will discuss with them about it and review if they feel it's appropriate for me to review it.
Okay. All right, so Dr. Bell, can you give us some examples of serious, of what can be considered a serious medical need?
Objective
Uh,
form.
It depends on what you're referencing as a, a location or space.
Okay, and the reason I am asking that because I am looking at your report. Oh. And it discussed the fact that you were not able, excuse me, that the jailers could not have known that Mr. Phillip was experiencing a serious medical need. And I just was curious as to if you had a rundown of a list of what can be considered a serious medical need.
Objective form.
I believe I was saying he was not exhibiting signs of a serious medical condition. And again, it's, agitation and bizarre behavior is not a serious medical condition. That's obvious for a guard. An amputated leg bleeding out would be a serious medical condition. Having fallen off a second tier level and have unable to move his arms and legs would be a serious medical condition. Having a seizure, tonic-clonic seizure, would be a serious medical condition that I would expect a guard to recognize as something that they need to get immediate medical help with.
Okay. Do you disagree that a person that's in an altered mental state can also suffer a heart attack, a cardiac arrest while in the altered state?
Objective form.
I guess if you're asking, is it possible that somebody with altered mental status could end up or an altered mental state end up having a cardiac arrest? The answer is sure, could happen.
Okay. And I wanted to talk to you a little bit about the toxicology report. I think you kind of talked about in your report about the fact that there were not, excuse me, that it might have been the deposition, I'm sorry, that there were not, the toxicology report didn't indicate whether there were illicit drugs taken by Mr. Phillip. Do you know, do you remember that?
Objective form. UA, was there a toxicology report? There was an autopsy.
Yeah, well, that's what Dr. Velk indicated. That's why I was asking about that testimony. But yes, there was, by the way, just for your clarification, there was.
All objective form mischaracterizes prior testimony.
And if I am, Dr. Velk, you can clarify it for us. I believe that your testimony, your previous deposition, you discussed the fact that the toxicology report doesn't always catch illicit drugs. And I'm summarizing. That's not verbatim what you said, but you can clarify what you said if you like.
Objective form.
To be specific, my report reflects that although his toxicology screen was negative for the common drugs of abuse, there are many other stimulant drugs that can create this type of sudden presentation that are not picked up on these basic drug screens.
Okay. And do you know exactly what was tested for in Mr. Phillips' case?
I believe I saw I'd have to pull the drug screen back up. It looked like a routine drug screen, which usually has methamphetamine, cocaine, PCP, marijuana, opioids-ish type stuff. So it's usually a base. I'd have to pull the records and double check that, but that's what I recall.
Okay. And okay. All right. Um, Now, as a part of your opinion, you indicated that Mr. Phillip was not experiencing a need for, I'm sorry, not experiencing an emergent medical condition. Am I correct with that?
Objective form.
I believe I said he was not exhibiting signs of a serious medical condition
Okay.
that a jailer should be able to recognize.
From the jailer's perspective, correct?
That's my report reflects, yes.
Okay. Now you have made it specific to jailers. What about the medical staff?
He presented agitated and, acting in a bizarre manner. That is a condition needs to be evaluated. I would not consider it a sign of a serious medical condition, but it needs to be further investigated.
Okay. Can you tell me, if you can, it looks like on your report that you indicated that Mr. Phillip had been aggressive. Can you tell me what you mean? Like, can you define the medical term aggressive?
Objective form.
Can you show me where you're seeing that, just to make sure I'm the
Yeah,
same?
give me just one moment. I'm trying to pull up your report. I apologize. I got out of that screen. And while I'm looking for that, is there a medical term for aggressive? Is aggressive a medical term, in other words? I'm sorry.
Objective form.
Aggressive is used in the medical language, yes.
Okay, so it is a medical term, correct?
Objective form.
Well, it's used in medical language. If it's a medical term, it's aggressive growth tumors, aggressive therapies. That's used in medical language. I'm not sure if it's a medical term specifically though.
Can you tell me what that term means when, like, for your example, aggressive cancer or condition? What does that mean?
Typically, it means an accelerated or it advances quickly, moves quickly.
Okay, and it looks like you did not indicate that Mr. Phillip was aggressive in your report. I don't see that. Okay, he was acting bizarre, but not aggressive. Okay, hold on. And I apologize for misquoting you on that, but did you find in your reviewing of the records that he was I'm going to strike that. I'm sorry. Okay, now you indicated that in the last deposition, how a person is restrained. You said that you made some motions with your body, and you indicated that the way that a person is restrained in the ER are different types of ways, and you indicated that there's a way that a person might be restrained on their back in a position you call it the swim position. Do you recall that testimony?
I often refer to one arm up and one arm down as a swimmer's type position, yes.
Okay, and that's what I was going to ask you to clarify. That means one arm up and one arm down?
Yeah, yes, exactly.
Okay. are there any other positions that have names like swim that describe a position that you put a patient in?
Object to form.
And I'm not sure if that's common use. We use it locally a little bit, but I'm not sure if it's a common term to call it swim position. I just reference it because it's descriptive.
Okay,
And as far as other positions, I think the only one that tends to come up is they call a 4-point restraint, arms and legs each sort of off the side. But again, that's, I think, more defining that there are 4 extremities being restrained rather than the actual positions of them.
okay. So are there any other maybe local terms that you all use for different types of restraints besides swim and 4-point?
Object to form.
Not that I can think of off the top of my head, no.
Okay. Now, relating to the 4-point, you said there's no specific position for the 4-point, just can you clarify that for me? The 4-point and how the different positions a person can be in with the 4-point restraint?
Object to form.
Sure. A 4-point restraint implies that all 4 extremities are being restrained. And typically as the legs are each restrained and down near the foot of the bed, so they can't kick up and bring their knees up. So it's usually in full extension. And then the arms are either at the side or above their head. So it's sometimes be like this or like this, depending on the situation and what the security team is opting for the best safety of the individual.
Okay.
Or again, or swimmer. Again, swimmer would be a 4-point restraint, I guess, right? Because it's all 4 extremities if you get the arms and the legs restrained.
Okay.
It's just a matter of where the arms are positioned that may vary. And again, I referenced the swimmer position because it's a local term, because it's sort of descriptive of one arm up and one arm down, like a swimmer would look like. The others are just, just 4-point restraints, and then they can be in any of the positions, arms up or down.
Okay. And so you mentioned what the security decides that's safest for the patient. Is that correct?
There's a team approach, but security usually runs security. They're securing the patient, and depending on what they think is good and safe, they'll often do. And there's very different scenarios. If there's a medical need for certain things, then we may work with them to adjust things. So, but usually the security is working to get them secured before medical moves in.
So ultimately, it's the security's call, correct?
It is
Object to form.
the security aspect of security's call. If there's a medical need that needs to be addressed, that we need to change a position or move something or whatever, then it would be, we certainly would have the discussion with them about, let's move this arm over here so that we can do X, Y, or Z type of thing. So it's their decision for their initial restraint, but that can be modified based on medical needs.
Okay. And if based on the medical needs, the position needs to be changed, and security does not agree, who gets the final say?
Object to form.
I think usually there's a discussion that occurs, and it's not final say, it's the best decision made based on the information. Security doesn't want to move for a reason. We'd have to discuss what that reason is, and then determine whether the medical need is superseding that concern for safety versus not. And we'd have to have a discussion and come with an answer. It's not a one person trumps the other person. It's a collaboration.
Okay. And who determines what's the best course for the patient?
The team,
Okay. And the team being?
those are involved in the care, the security person, doctor, nurse, depending what's the aspect being discussed.
Okay. And if the team can't agree, what decision goes forward?
Object to form.
Depends on if you're talking about a hospital setting. If there's a high security risk and that we can't move something for a medical reason, usually they will move it. And so I think usually at some point the medical part, if it's truly necessary, will happen. But there's sometimes it was more for convenience and the risk of moving is not. And so then we decide it's best to leave it in the position it's at. So again, there's not a blanket statement that, in this case, decision will be made over that decision. I think there's a collaborative decision made in the end, and it's what's best for that individual at that time.
Okay. And if it's related strictly to treatment, that would because obviously the medical team would only be concerned about the patient's position if it relates to that patient's medical need, correct?
Object to form.
I'm not sure I followed that one. Could you?
Yeah, sure. So the medical team would be concerned with the patient's position as a result of that patient's need for medical care, correct?
Object to form.
It depends. And again, we're sort of in hypotheticals here as far as scenarios go. And so it may be a medical need to try to get an arm down for a shunt for dialysis access or something like that. There's certainly different scenarios you can come up with. But sometimes it's decided, for an IV placement or other reasons. And so again, it's a very vague scenarios, but it's decisions. If there's a question about moving something, it would be a collaborative effort.
Okay. Let me ask it in this other way. So medical is not just going to go in and tell security to change this person's position unless they're trying to perform some sort of medical care. Is that correct?
Object to form.
Not necessarily.
Okay. When would medical tell the security that they need to change this patient's position if it's not for a medical care or medical need?
Object to form.
Well, medical care is what you were referencing originally. I guess if somebody was uncomfortable with their arm above their head because their hand was falling asleep or just wasn't comfortable there and they were calming down a little bit, we'd like to move their arm down to maybe get them to be less upset or agitated or yell less, sort of a collaborative effort to try to calm the patient with a discussion of, hey, how about if we move your arm down there? I know it seems to be bothering you, but you can't be yelling in the emergency department, et cetera, et cetera. That might be an option. That might be something that's not really a medical care issue. It's more of a working with the patient to try to get them to be a little more calmer. And so that would be something that we might ask security to do that and collaborate on that.
Okay. I want to go back to, I just want to clarify because I wrote this note down about the 4-point restraint in the swim position or swimmer's position. Is it swim or swimmers or both?
It's not even a real term we use locally. So I think some people call it the swim position, some call it the swimmer's position. It's descriptive more than something you would write in a note.
Okay, I just didn't want to get it wrong here. So in the swim position, when you were talking about the 4-point restraints, you mentioned that sometime the swim position, well, I want to ask, is that swim position sometime a 4-point restraint, or is it all the time? In other words, is sometimes the swim position just restraining the arms and not the legs?
Object to form.
The position could be just arms potentially. Sure.
Okay. All right. Thank you. How do you decide that a patient should be in the swim position?
Typically, it's not a decision that I'm making as a medical person. It's usually security's decision. And it may be personnel, it may be the individual that's there, the strength of them. It may be what's going on, as far as that goes. So that would be more of a security question as to why they would sometimes choose one over the other. Sometimes it's a matter of how long the arms are and bed and size and stuff like that too. If they're very long and tall, then it may not be a good position because the arm would be hanging off the top of the bed rather than on the bed.
Okay. And is medical, are security, the security that you're referencing, are they medically trained? Is it a medical arm of the, is it a security arm of the medical department where they're actually licensed medical providers making these decisions?
Object to form.
At my hospital, they are their own departments. Security is doing that. That's our current practice. In years past, we didn't have a strong security force, so a lot of times it was done by medical personnel.
Okay.
And that may vary from hospital to hospital depending on availability of security.
Okay, and you testified before that you've restrained patients often, correct?
I have, yeah.
Okay, and how do you determine what's the best position for a patient, or when and more specifically, when to put a patient in a swim position?
It's truly a matter of what's going on at the time. We're not sitting there saying swim position is better than this versus that. Oftentimes it's a matter of getting people around the bed. So if it's a very big, large, strong person, often the swim position gets more people around the bed, but they're not all crowded together in the middle. So you have one up by the head there, one in the middle, two down by the legs. It gives us a little bit more space to move around. If it's not so much of a big person or a strong person or that type of thing, then it may be more on the side. But there is no written or expected, or in this case every time it'll be a swim position. In this case, every time it'll be a by their side position. There are options that are exercised, but without true guidelines written out that I'm aware of.
Okay.
Yue, before your next question, who's Christine Blackshire?
I don't know.
Because she's appearing in our participants.
Okay.
Ms. Blackshire?
Can we go off the record?
Sure, here, let's, the time is 11:37 a.m. and we are now off the record.
I don't think she's from our office.
No, she's not from our office, but she just appeared. So that's it. And I didn't mean to interrupt your rhythm there, Yue. I just don't know who this person is.
Okay.
Okay, so Ms. Blackshire is actually with legally under oath.
Okay. Thank you, Mario.
So she's with us.
What is her role? Why is she here?
Let me see.
I mean,
Right now she's training, so she's actually watching
okay. All right.
how I do things.
Good.
Okay. So yeah, if there are any other questions, we can get back on the record if y'all are ready.
I'm ready.
Okay.
Is
I'm
there,
ready.
so I don't know what the video is going to show that, but well, we're back on the record, I guess, right? You're already
Well,
recording, right?
Oh, I thought I paused it. Yeah. So, yeah, I'll just put us back on the record. But yeah, so the time is 11:38 a.m. and we are back on the record.
Okay. All right. Dr. Vilke, she's not muted. Can she be muted? Okay, thank you. Oh my goodness. All right. So, Dr. Vilke, can you tell me, I think where we left off at, we were discussing the fact that you have restrained individuals yourself, and that there's not a specific formula that if a person's that a person should be restrained in this position for this situation or this position for that situation, correct?
Not from the medical side. There may be something on security's end that they may have policies and procedures, but I'm not aware of that. From the medical perspective, what my involvement has been, no.
Okay, and so the medical personnel doesn't get input on that decision, correct?
Doesn't get
Input on the security's decision on how to restrain a person, correct?
Objective form.
I think we discussed this earlier. If there's a medical need or a position that might be better for that individual, for comfort, for medical access or things like that, then there could be discussion on that. But initially, if there's an aggressive person, that'll be managed by security in our facility with medicals who are standing by until it's secured.
Okay, and security is not trained medically, is that correct?
Objective form.
They are not, they may have some background in first aid or, other training, I don't know. But I don't believe that they are required to have medical training. They're not part of the medical team in the sense of giving medical care. They don't do CPR, they don't do medical administration, they don't do assessments, but they do stand by and assist us with our patients.
Okay. And I want to ask you a little bit about the physical restraints. Now, again, you testified that you have yourself been involved in restraining patients physically. Is there a protocol in restraining patients before making the decision to restrain a patient physically, like any de-escalation measures that are taken at all?
Objective form.
Yeah, there are certainly, I guess, guidelines on how to approach the agitated patients. Verbal de-escalation would be something to work with, certain show of concern, things like that. But yeah, there are sort of aspects that we do depending on the scenario and the situation.
Okay. And all right. And what about calming techniques?
Objective form.
I'm not sure you're asking me specifically.
Yeah, are there, is it required to employ calming techniques prior to resorting to physical restraints?
It's not required, depending on the scenario. Somebody comes in and they're aggressive and violent and throwing things around, you might try to, hey, get some space back down, but it may go quickly into physical control depending on what's going on. But yeah, they're part of our armamentarium of things that we can use for the agitated patient, depending on level of agitation, what's going on in the scenario.
But isn't that recommended to employ a calming technique?
Objective.
I'm sorry, isn't it recommended that prior to restraining a patient that you should attempt calming techniques?
Objective form.
Yeah, if feasible, depending on the scenario, verbal de-escalation, calming techniques, backing off, depending on the scenario, location and things like that, the level of communication you have with the individual, if they're able to understand and follow commands or not. So it's part of the process, and I'm a big fan of it. If it can work, it's wonderful. A lot of times you can talk people down, but there's other individuals that doesn't matter what you're going to do, it's going to be a need for restraints. So it is a technique that's used though.
And that's the same for a patient that's agitated, correct? You want to kind of go through the same measures of de-escalation as you stated, verbal de-escalation and other calming techniques. Is that correct?
Objective form.
Again, it's a very generic commentary. If I come into a room and a patient's yelling at me, first thing I'm going to do is try to use some verbal de-escalation and calming techniques. If they are attacking me, I'm probably not going to be able to get to that level. So it depends on the specific scenario.
Okay. All right, and do you agree that when vital signs are abnormal, that the medical causes of agitation should be considered?
Objective form.
I mean, agitation often comes with abnormal vital signs due to the agitation. So I think you have to sort of put into the context of when and how the vital signs are taken, what they are. The blood pressure is 60/40. Yeah, that would not be typical for agitation. You certainly want to look for a medical cause there. So it depends on what the vital sign abnormality is.
Okay, and what if it is that in fact that the blood pressure is higher than normal? could that be a cause of elevated blood pressure be a cause of agitation?
In and of itself, an elevated blood pressure doesn't typically create agitation. It's often a byproduct of agitation. When we get agitated, our blood pressures often go up. But isolated hypertension would not be a typical cause for sort of agitation in general. I mean, again, there's different types of agitation, but in general wouldn't be a common. If you're 90 years old and your blood pressure's up and you're having a stroke from it, it could create some agitation. But again, it's, you know, there's a lot of openness to that question to discuss.
Okay, and can you tell me if what are some medical causes that manifest in the form of agitation outside of psychosis or any kind of mental health issues?
Objective form.
Sure. I mean, drug intoxication is probably our most common one. Alcohol intoxication can really cause agitation. Medical causes, Alzheimer's, dementia certainly causes agitation in individuals. Seizures and post-seizure confusion can cause altered mental status and agitation. You know, certain types of you know, so for example, if you had thyrotoxicosis, that could cause, you know, some agitation, altered mental status. And I think we're talking about agitation specifically. You know, so you said psych, no, but I guess just general frustration or pain, I guess, could potentially cause agitation depending on what's going on there. You have a broken leg and a big femur and you're in a lot of pain and people moving around, that can cause some agitation. So I guess there's a number of things that can cause agitation. It depends on what degree. There's, you know, low sodium can make you confused and maybe a little agitated, but not violent. So again, it's how you want to define agitation.
Yes, okay. Can you tell me if, well, you know, let me just preface by this question. How do you determine if a patient is unstable,
Objective form.
medically unstable?
Objective form.
Again, it's a very open question. You know, as far as things go, one area of looking for stability might be the vital signs themselves. You know, for unstable and septic shock, we're looking for low blood pressures. We're looking for significantly elevated heart rates without an obvious source. Low oxygen saturation. So it depends on the clinical scenario. Because, for example, if somebody is having a lot of pain, you expect their heart rate to be up, their blood pressure might be up. So again, you sort of parse it with the clinical scenario. So it depends.
Okay. And have you ever, in your practice, recommended at a patient I'm sorry, give me one moment. Have you ever recommended in your, as far as your practice is concerned, or, you know, recommended to anybody else, that a patient who is unstable be restrained?
And again, the term unstable, if you're talking about, you know, physically aggressively unstable and volatile, you know, that's certainly a population that often will end up being restrained for safety purposes.
Okay.
If you have a 90-year-old who has a stroke and she's getting medical care and maybe other things going on and she's agitated from her dementia and Alzheimer's, she might get some, you know, we call it adaptive support device to keep her from pulling lines out and IVs out. That would be, you know, she could be medically unstable, and we'd be recommending the use of those devices in a sense is restraining her from impacting her care. So I guess the answer would be a yes, depending on the scenario.
Okay. And Have you ever recommended that a patient who is unstable, kind of from the examples that you've given, be secluded as they are restrained?
So the agitated, aggressive person, some of our PCP, cocaine, methamphetamine intoxication people, they often do better with a secluded environment, a quiet room, closing the curtain, dimming the lights. Once they are restrained, is to help the calming process. Often they'll get medications at some point, but in general, all those will be employed to try to treat the individual from their agitation.
Okay, so you have recommended that a patient that has been unstable, kind of from some of the examples that you've given, drug intoxication, and had that patient to be restrained and secluded, correct?
Objective form.
Yeah, it is, I guess, secluded in the sense that I'm referencing, quiet room, closed door, or door open, curtain pulled, lights down a little bit. Sure. We've done
Okay. All right. And what about a patient that has a history of a heart condition? Have you ever recommended that a patient that may be agitated who has a history of a heart condition be restrained and secluded?
that.
Objective form.
I guess the question, it depends on the known heart condition. If they come into my place and they're just agitated and I can't get any history from them and I need to, protect the environment, the answer would be sure. We have to start with A, B, C, get them in a position where we can actually assess them, and that would be seclusion and restraints. And then you start sorting through the background on it.
Okay. Now, the background because I just provided that they have a known heart condition. So that is the background. They have
That's fair. Okay.
In that instance, have you had a patient that has a known heart condition that presents in an agitated manner, restrained and secluded?
Objective form.
I guess in my history, the answer would be yes. If they come meth intoxicated and they'll have, we may know that they have some cardiomyopathy due to their meth use or some other heart condition there. The priority is the agitation and the security. And then ultimately we would start working out to see if there's anything that's connected with the heart or not, or any other medical conditions, or if it's just, in that case, drug intoxication is causing the agitation.
Okay. And I know you added the drug intoxication fact to the scenario, which is fine. I'm perfectly fine with that. Outside of a drug intoxication, a patient that is known to have a heart condition who is agitated, have you recommended or required a patient under those circumstances be restrained and secluded?
Objection form asked, answered, and also assumes facts not in evidence.
So agitated, so your hypothetical is the agitated patient with a heart condition, and you're saying, I think, known heart condition. Would I ever recommend, or have I ever recommended, or could I ever recommend seclusion and restraints? Is that you're asking? Yeah. The answer is yes. Yeah.
Okay. All right. And so you have recommended restraint and seclusion for a patient who has had a known heart condition that presents in an agitated manner, correct?
Objective form.
Answer is yes.
Okay. Can you tell me about the circumstances that you had a patient that had a known heart condition that was agitated that you restrained and secluded?
Sure. We've had patients who come in who have pacemakers in, so they have a known heart condition, they're agitated, and then we have to get them calmed down. So they would be restrained to get to the level of evaluating them. So the security issues come first, so they can actually start medically evaluating or calming with medications if necessary to get to the point of medical evaluation.
Okay, and that's fine, but I asked specifically about the times where you've had that patient restrained and not calmed, rather secluded, restrained and secluded.
Right.
Objection form asked and answered.
Right. The seclusion is the initial part of the calming, right? Separate them out, get them just undistracted. But ultimately, you're going to start, if they don't start to calm down on their own, then you're going to decide if you want to use medications to facilitate the calming. A lot of times you put them into a quiet room, not much distraction, keep them from moving around a lot. They will, in fact, calm down. So that's the initial part of the calming, is the seclusion itself.
Okay, and so you put them in a quiet room, and that's a calming technique, in your opinion, correct?
Objection
Part of-
form asked and answered.
It's part of the process to try to initiate calming, that maybe you don't need ultimately to use medications, or maybe you can get them to take oral medications instead of having to give them an injection, or maybe they won't need any at all if they start to calm down and the restraints can come off later without having to do anything. It's
Okay.
part of the process of initiating the calming milieu.
Okay, and can you tell me if the patient is left alone as they're secluded with nobody near them?
Sure, there are certainly times when the patient is left alone with the room there, the curtain pulled, while they're in the process of, after they've been in a sense restrained and getting things set up for them. Yeah, they're not always having somebody by their side.
All right, and are they on monitors at all?
Sometimes yes, sometimes no, depending on the circumstances.
Okay, so it's your testimony that sometimes you'll have a heart patient who you have decided to restrain and seclude, who presents agitated, that you will leave alone in a room without monitoring, correct?
Objective form.
That's not what I said.
Okay. Well, correct me, I'm sorry.
I guess you're saying that's my test. That's what we would do. And again, you're asking scenario-based things. Is it possible that there are patients who come in with a cardiac condition that are agitated, that get put into the seclusion with restraints to get them in this calming mechanism, that initially don't have monitors put on them? Yeah, that's not the first thing that often goes on some of these patients when you're trying to get them calmed down and they're agitated. Sometimes the monitors bother them, the beeping bothers them. And so it's a case-by-case scenario based on what you're finding, what your clinical scenario is at the time.
Okay. How long do you recommend that a patient be left by themselves alone in the room, secluded and restrained, if they are agitated with a heart condition?
Objective form.
Again, it's a very open scenario. It depends on what's going on, what the heart condition is, what the level of agitation is. So there's not an answer for that.
Okay. Is there a range?
Objective form.
It depends on what's going on in the ER, what's going on at the time, what the patient's level of agitation is, how they're changing over time. So there isn't a range. I'm not going to say it's 5 minutes to 60 minutes. It depends. It could be that range. Depending on the clinical scenario. It could be longer, it could be shorter. But as far as being, and again, the scenario is there's people listening in, there's not people listening in, there's people outside looking at other patients, but not immediately in the room. The patient could be alone in a secluded room for a significant period of time while they're in the phases of either yelling or starting to calm down. Because when you go back in the room, they start yelling again, let them calm down a little bit. And so we do often leave patients there for some period of time to get into that calming phase, and then go reassess them, potentially put them on a monitor at that time. Again, depends on the scenario.
Okay. And just to be clear, when you say we, do you mean at University of California, San Diego Medical Center, that the medical team there has decided to leave patients that have a known medical condition, heart condition to be specific, restrained and secluded in a room alone for up to 60 minutes, correct?
Objective.
I did not say that.
Okay. Tell me when you say the University of San Diego, University of California, San Diego, medical team does as it relates to, or has done in the past, relating to leaving a patient with a heart condition that's agitated, restrained, and secluded. What's the longest length of time that you can say that the medical team there at University of California, San Diego, has left a patient in a room secluded?
Yeah,
Just a form.
I can't say for certain. I've taken care of hundreds of patients that are agitated, that are restrained, that are secluded, many of them with heart conditions, because that's part of the, in their cases, drug use history. That's part of that. You know, sometimes the nurses walking by and checking on them, listening in or whatever it is. I don't sit there for 60 minutes and say, has anybody come by and seen this patient or not? But there are times where things are busy and patients are, you know, we've got 50, 60 patients going on that somebody may not have gone in and physically touched a patient for a period of time. I can't give you the answers to that. I don't know exactly how often or how many, but the scenario certainly is a possibility and is likely happened for periods of time. 60 minutes, I don't know. You know, if we have a code coming in and the team's pulled over and the person's still yelling and nurses are covering for each other and they're hearing him still yelling a little bit, there may not be something going in immediately for that. So, but I can't give you an example. I can't give you an exact time or a patient name. But the possibility is that, yeah, we do leave people to calm down a little bit initially when they first get there, depending on the scenarios and how agitated and how violent and how aggressive or not.
Okay. So there are times when, well, you know, let me not assume what the term monitoring means. Can you tell us what the term monitoring a patient means?
Objective form.
It can be cardiac monitoring where you put them on a cardiac monitor and look at their heart rate and it's put on the machine. It could be just monitoring them for, you know, eating and drinking, you know, type of thing. Somebody who is intoxicated, who's waking up after being in our ER overnight drunk, and monitoring their progression of waking up and, you know, grabbing the breakfast off the tray there. So it's any level of observation. It could be a level of hearing somebody in a room there. You know, the guy is still in there and he's babbling on, or he's talking about this, or he's on his phone. Who knows? That could be a degree of monitoring to see what their status is, depending on, again, the clinical scenario, what's going on at the time.
Okay, and I just heard you mention observation interchange with monitoring. Are they interchanged? Are they used interchangeably, the terms monitoring and observation?
They could be, sure. There's could be direct observation, or indirect observation would be the same as, you know, monitoring somebody's level. I think people use them interchangeably depending on what scenario. I don't think they're always used interchangeably. You wouldn't call it cardiac observation, it would be cardiac monitoring. So they're not interchangeable, but at times it could be.
I see. Okay, and now I'm talking specifically as it relates to restrained patients that are secluded, and your experience with the University of California, San Diego, and leaving patients without observation. Now you mentioned that you could understand times where you all have left patients restrained and secluded without observations for an extended period of time, maybe up to, from 5 to 60 minutes. Is that correct, or is that something that I'm mischaracterizing in your testimony?
Objection form.
I said there could be scenarios in which it has happened. I don't know if it has specifically happened. I couldn't give you a time. That's why I sort of said 5 to 60 minutes is a possibility. Sometimes we have people indirectly observing them, meaning they're sitting outside the room observing our psych patients and listening in to the person in the room there while they're being secluded. But it's not a direct monitoring. It's not cardiac monitoring. It is sort of listening and making sure that they're not getting out of bed or doing something different. And if there is a change in status, they would go and reassess that person.
So it's your testimony that the University of California, San Diego will sometimes leave a patient who is restrained and secluded and observe them, not by visual, but just listening to them as a method of observation only. Is that correct?
if we pulled the curtain on them, it's possible that could have happened. Sure. Again, I'm not a nurse, so I don't know if they're the rules, but I have seen patients that we're trying to calm down by pulling the curtain a little bit, letting them calm down a little bit, and then reassessing them. So yeah, there are times where a person could be with a curtain pulled and restrained for a period of time with not somebody sitting in the room. Sure.
Okay. And what period of time are we talking about here that the University of California, San Diego allows a patient to be restrained with a curtain pulled and just a person listening outside of the curtain for observation purposes?
Objective form asked and answered.
I don't know what the university allows. I'm just saying that because I am not over there watching them. The nurses have their protocols about certain things. So I don't know the answer to what the university itself allows is what you're asking.
Well, no, you work for the University of San Diego, University of California, San Diego Medical Department, correct?
I do.
Okay, and that's what I'm referencing.
Right. You're asking what they allow, what the university allows, not what may happen when we're taking care of patients. I don't know if there's a policy that has certain specific criteria. That would be what you're saying allows. I'm just saying that there are times when we get somebody in there who's agitated or very drunk and violent and this and that, but we just give them a little time, a little quiet, he'll calm down and go to sleep, and then we'll take the restraints off, we'll get him back on the monitor. That does happen. Again, if you're asking what time period and things allow for, I don't know a specific answer if that's a policy or so.
Okay. What about when you worked in the jail? Did you all ever restrain and seclude a person in the San Diego County jail system, medical department, and leave them, the patients there at the jail, monitored outside of a secluded area where they're secluded with simply just listening to the patient?
Objective form.
There are times we've had agitated patients that were put into isolation areas that were basically in the, you could hear them yelling and screaming. We'll get to them eventually as part of the sick call, but they are not being directly observed. They're not being directly somebody in the cell with them. No, they're not being put on a cardiac monitor. So yeah, I guess there are times where they would be agitated in a secluded area.
Are they restrained also?
Objective.
That at times they may or may not be. That would be a deputy decision of the jail. Sometimes they might be, sometimes they may not be. Usually it would be if they're aggressive and agitated.
Okay.
And rousing up.
So in your experience, you have had individuals in the San Diego County Jail under your care that you've seen restrained and secluded and without visual observation on that patient and leaving them there for a certain period of time. Is that correct?
Objective form.
I guess under my care is they're down there to be seen at some point. So they will be evaluated. They may not be under my care at the moment, but they're down for evaluation. That have been put into a cell that may still be restrained. And the idea is to sort of keep them in that secluded cell by themselves to help the calming process. Yeah, that's been done without direct visualization.
Without without visual observation, correct?
Without direct visual observation, yes.
Okay. And for what length of time?
Depending on how long they're yelling, what's going on, it could be for 30 minutes, 60 minutes, depends what's going on and how disruptive things are, what needs to be addressed. So it depends in the scenario.
Okay, so just to be clear, your testimony is at the San Diego County Jail when you were there, Sandy, that there would be patients that you would leave restrained in a secluded area and not perform any visual observation for up to 30 minutes or more. Is that correct?
Objective form.
That I would not perform a visual. Yeah, that's certainly the case. Does somebody walk by them once in a while? It's possible. I'm not sitting outside the cell doing a stopwatch looking to see if somebody's popped their head by or not.
Okay.
But not that somebody's sitting posted outside the cell watching them and making sure that the status isn't changing. There's auditory obviously cues with yelling and screaming that you get, but could somebody walk by and the person there? It's possible. So I can't say it's not 60 minutes or 30 minutes without anybody looking over, but they're still yelling and screaming, and then yeah, we'll get to them when we have a chance to get to that patient.
Okay. All right. And if a patient is restrained in a 4-point position, are there any special or different precautions that you would take versus a maybe, you know, just a wrist restraint?
Are you talking about the emergency department? You talking about what scenario are we talking about? You know?
Yeah, so the emergency department.
And now that I clarified that, I forgot the original question. Can you please repeat
I'm
that?
sorry. No, I was asking, is there a different set of precautions that's taken for a patient that is in a 4-point restraint versus maybe just a wrist restraint in the medical department?
Objection form.
I'm sorry, medical emergency department.
Objection form.
Yeah, I mean, if they're in a 4-point restraint, there's a process that goes, there has to be an order for it. There has to be reassessments at certain times. As far as that goes, we try to get them out of the restraints. We try not to keep them there in a prolonged period of time. So as far as that goes, yes, there are processes that go into play.
What about at the San Diego County Jail? If a patient's in a 4-point restraint, are there special precautions in place there as it relates to dealing with those patients versus a wrist restraint?
Objection form.
Yeah, I think typically the patients we saw that would be restrained at the jail were more waist chain shackled rather than 4-point restraints. So they may have leg shackles and wrist shackles that way, but not necessarily in the classic 4-point restraints.
Okay. So you haven't really dealt with patients at the jail in a 4-point restraint, is that correct?
Objective form.
Yeah, our medical table did not allow for 4-point restraint placement. They could be put onto a gurney with restraints, you know, the spider strap restraints if necessary, or have their waist chains put on if there was a need to control them, to assess them. But as far as putting them on a medical gurney, we did not have that facility at our place.
Okay. Have you ever trained anybody on what to do in dealing with a patient that's in a 4-point restraint?
Objection form.
I guess I've trained residents and medical students on approaches to the agitated patient, which might include somebody who's in a restraint, sure.
Okay, what about a 4-point restraint?
Well, that would be part of the restraining process. And most of the time, if you're going to restrain somebody, it ends up being 4 points, unless it's more of a medical need. If somebody's violent enough, aggressive enough to need restraints, you usually start off with 4 points, and then you work your way backwards and start taking them off after they start to calm.
Okay. And as it relates to the 4-point restraints that you've trained your residents on, can you tell us a little bit about what you have trained the residents on relating to the 4-point restraint? I kind of see that you went into a little bit working your way up to removing them, but can you just give us kind of what you've instructed your residents on dealing with the 4-point restraint and some of the precautions?
Yeah, I think we've touched on this throughout this morning, but basically it's the approach to the agitated patient that includes the 4-point restraints. And so you're doing your verbal de-escalation, your calming techniques, and then potentially if you need if the security requires for the patient and the staff the need to restrain them, then it's, you know, often going to be a 4-point restraint because it's the safest way to control somebody for a period of time. You put them into a calming milieu, try to sort of let them calm down depending on their etiology of their agitation. A drunk person often calms down when everything sort of settles out. Somebody who is intoxicated on a stimulant drug often does not. And if they're not calming down, then you sort of look at, you know, your next steps of, do we need to give sedating medications or not, or calming medications? And so that's, you know, sort of the part, you know, part of the training that goes with that. And if you're going to use medications, then you're going to, if you give that, then you're going to want to, as they start to calm down, put them onto a monitor so you can sort of follow their vital signs at that point.
Okay. How long would you say that this process should take in making these determinations
Objective form.
on the
It-
steps you outlined?
It varies depending on the clinical scenario.
Okay. What about in a jail setting?
And I'm sorry,
Well, you wouldn't know that, correct? Because you've never used the 4-point in a jail setting. Isn't that true?
well, I didn't hear what you said in a jail setting.
Yeah.
For the agitated patient there, that is a different scenario because we don't typically go and sedate most of the patients there. That if they're there for agitation, they're often, depends on the level of agitation. If they're in what we decide is excited delirium syndrome, they may get sent out to a hospital. If they're just agitated and angry or upset, then they may be calmed in a sort of an isolation seclusion area and let them calm down and then reassess them at that point. But as far as a 4-point, yeah, we didn't use that in the jail. We would keep them in either leg waist chains and shackles or the seclusion rooms.
Okay. And you mentioned straps also, correct?
If they were on a gurney, they got brought down, say maybe this man down on a gurney, they have spider straps that could be potentially holding them into place. Yeah.
And can you help us lay people understand what a spider strap is?
Sure. If you've ever looked at an EMS provider pulling somebody out of, the car crash, they put them in the backboard and they put these straps over them. That's basically they strap in and hold them in position so they don't roll off the backboard or roll off the gurney. They call them spider straps. So they look like when they're unstrapped, they look like a big 8-legged spider.
Okay. All right. And do you agree, Dr. Vilk, that a medical staff individual that decides to employ a 4-point restraint should be trained on the 4-point restraints?
Objective form.
Typically, there's training for the medical providers on how to use a restraint if they're using it. Like our facility, the security also does that, so they have some training in how to restrain individuals.
Okay. And do you believe that they should also be trained and be familiar with adverse effects of being in restraints?
Objective form.
Sorry.
Who's they? I'm sorry.
The medical staff. Do you think that they should be familiar with any potential adverse effects of a patient being in a 4-point restraint?
Objective form.
I guess there should be, from that, sure you're referring to adverse effects. It's a restraint. So I guess looking at wrists and fingers and stuff like that, that's something that they would be trained in. So I guess there would be some level of training. Yeah.
No, well, I didn't ask if there were training. I asked, do you think that they should be familiar or trained on how to identify or just even recognize adverse effects associated with being in a 4-point restraint?
Objective form.
Yeah, I guess there should be some level of familiarity with it. Yeah.
Okay. What about should medical staff be familiar with any adverse effects that can result in a patient being in a 4-point restraint and secluded?
Objective form.
I guess, again, back to familiar, sure. If you're going to be having patients in restraints, you should have some familiarity with the use of the restraints. I'm not sure the seclusion makes the change the scenario that much, but sure, it seems like it's where they're located rather than what's actually happening to them. So I guess a familiarity would not be unreasonable.
And you testified previously, we talked a little bit about you kind of taught me, I guess, showed me the way as it relates to how to use the word prone and the prone position with patients. And you indicated in your previous testimony that the prone position is sometimes used for patients in certain circumstances. Is that correct?
Objective form.
That is correct, yes.
Okay. And I think you talked about the fact that you didn't see any issue with Mr. Phillip being placed in the prone position when he arrived in the jail medical department, correct?
Objective form.
Yeah, I have no problem with the prone position from a physiologic perspective.
Okay. Have you ever recommended a patient be restrained in the prone position in a 4-point restraint?
I'm trying to recall. If Mr. Phillip was restrained prone, I thought he was not restrained prone. But we've had patients who have been initially restrained prone, but then flipped over eventually.
Okay, have you had a patient, I'm sorry, were you finished?
Sure.
Have you had a patient that was restrained in a 4-point restraint in the prone position?
Objection form assumes fact, not in evidence.
I have had patients in the prone position restrained, yeah, in 4 points.
Okay, and under what circumstance, is that something that you ordered that the patient be restrained in a 4-point in the prone position?
It's not something I order now.
Okay, when you were in that situation where you had a patient that was restrained in the 4-point position, in the prone position, excuse me, did you allow that patient to remain restrained in the 4-point position in the prone position?
Objective form.
They were given sedating medications and then eventually turned into a supine position.
How long were they, did they remain in the 4-point restraints position after getting the medication?
Yeah, this is a very long time
Objection
ago.
form.
A very long time ago that I can't give you exact times, but it's basically until they started to calm down a little bit. So that could be 15, 20, 30 minutes, depending on the event at that time.
Okay, so you have allowed a patient to remain in the prone position in 4-point restraints for up to 30 minutes in the past, is that correct?
Objection form.
In the distant past, yes.
I'm sorry?
In the distant past, yes.
Okay, and this is while you were working at the University of California, San Diego Medical Department?
That's correct.
Okay. And was that patient, and that patient was given calming medication? Is that what's called a chemical restraint?
Objection form.
Some people will reference it as a chemical restraint, but yes, the calming medication being an intramuscular injection of something to calm them down.
Okay, and so so the patient that you've allowed to be in restraints, in a 4-point restraint on the prone position for up to 30 minutes, you mentioned that you put them on their back after they've calmed down, is that correct?
And I'm estimating, this is 25 years ago. This is a long time ago, but I know we used to have patients who came in restrained in a prone position at that time for safety purposes. And then so they got sedated and got flipped over when they calmed down. So I can't give you an exact timeline of 30 minutes, 25 minutes, 20 minutes, 40, I'm estimating that it takes some time to get the medication, give it to them, let them calm down, and then turn them over. So yes, 30 minutes is probably a fair estimate, but I can't give you exact examples.
Okay, do you know why you just didn't allow him to remain in the prone position? Why did you turn him over?
Objection form.
Typically, after we give sedating medications and they start to calm down, you want to put them on a monitor. And so it's easier to put them on the monitor when they're in a supine position.
Okay, so the only reason why is because it's easier to put them on the monitor?
Objection form.
I didn't say the only reason why, it's one of the reasons why.
Okay, what other reasons?
So that if you need to place an IV, it's easier to place it in the arm when the arm's flipped over. You can certainly observe them a little bit more closely at that point. If you need to put oxygen on them, you could certainly do that if need be, those types of things. And so it's just what we normally do in general. After we sedate somebody, you want to have them in a position where you can observe them a little bit better.
Have you ever placed restraints on a person yourself?
I have, yes.
Okay, what type of restraints have you placed on a person?
I've used both leather restraints as well as the, I guess this, call them soft restraints,
Okay.
Velcro restraints.
Have you ever put handcuffs on a person?
I have, yes.
Have you ever put leg irons on a person?
Leg irons, I have not put on.
Okay. Have you ever seen a person be placed in leg irons while you were there observing?
I have, yes.
Okay. Have you ever seen a person or have you ever removed handcuffs from a person?
I have, yes.
What about leg irons? Have you ever removed leg irons from a person?
I have not.
Can you tell me an estimate of about how long it takes to put handcuffs on a person in a medical setting? And I'm assuming it was a medical setting that you put handcuffs on a person. Am I incorrect in assuming that?
You are.
Okay, so tell me about the what was the circumstance where you put handcuffs on a person? Was it training?
A little bit in training, but mostly of my research on restraints. And so we would handcuff individuals as part of the process to evaluate their positions. And so we had to put them in handcuffs.
Okay, and how long does it take to put a person in handcuffs?
I mean, you're talking about, it depends, I guess is the answer. If they're compliant, it doesn't take very long at all. If they're fighting and struggling, it could take minutes, right? So it depends on how long what the scenario is.
Okay, what if they're compliant? About how long would it take?
Objective form.
Even 5 to 10 seconds, fairly easy to put on.
Okay, and what about to take off? How long does it take? And I'm
Objective,
compliant with that, but about how long would it take to get them off?
objective form.
Same answer, depends on how compliant they are. If they're moving around, it's hard to get a hold of them, then it could take a little longer. If they're compliant, then putting the pin in there, the same thing, 5 to 10 seconds shouldn't take very long to do at all.
Okay. All right. And in your witnessing or just observing a leg restraints being removed and put on, would you say it's about the same length of time?
Leg restraints in a compliant person, just very easy to put on because you don't have to move anything, just slip them on there. Taking off, same thing, 5 to 10 seconds.
Okay.
If there's a good time for a break, I don't want to interrupt your flow, but if
Yeah, we can take a break now.
Can we do 10 minutes this time?
Yeah, sure.
All
As
right.
long as Dr. Vilke, I'm fine with it.
sure, thank you.
Thank you.
Okay, the time is 12:28 p.m. We are now off the record. The time is 12:41 p.m. We are back on the record.
Okay. Dr. Vilke, let's see, I probably should have checked this out already. Okay, so we left off with discussing the 4-point restraints and whether and when a person should be aware of, I believe, their any adverse effects related, or if a person in medical should be aware of that. But I'm going to shift a little bit from that line of questioning and ask you about whether you have, I'm sorry, we were talking about the length of time of having their restraints on and how long it takes to remove them. But I want to ask you, can you tell me if you have any articles or publications that recommend leaving a patient in a 4-point restraint without observation?
Objective form.
Do I have any articles that say leaving 4-point restraint without observation? I don't believe so.
Okay. How about any articles or publications that state that it is safe to leave a patient in a 4-point restraint without any visual observation?
Objective form.
I'm not aware if there's any articles that I've authored with that on there.
Okay. Are you aware of any articles or publications that recommend that a person in a 4-point restraint that is secluded be monitored by listening only?
Objective form.
I'm not familiar. They would say something to that exact language now.
Okay. And you haven't written any articles to that effect, correct?
No, I don't believe so.
And nor have you engaged in any research to that effect? Is that safe to say?
Secluding and yeah, no, nothing like that.
Okay. Now, as far as Mr. Phillip in this case, being agitated, isn't it reasonable that he would experience a level of agitation being increased after he was placed in restraints, a 4-point restraint?
Object to form.
Is it, and I missed the part, is it reasonable to expect that that would happen, that he would increase his agitation?
Yes.
I don't think it's reasonable to expect that, no.
Okay, why not?
Because a lot of people who, once they are put into a position where they can't do a lot of activity and they're not being stimulated, actually start to calm down.
Okay, but as far as Mr. Phillip is concerned, there's testimony and evidence that you have reviewed that indicated that he did not calm down. Isn't that true?
Object to form.
He did not initially calm down right away, but there were some points where he started to get quiet, which is when they went to evaluate him.
Right, but that's when he was in cardiac arrest also, correct?
Object to form.
We don't know if he went to cardiac arrest at that point or if he was calming down right before that. But it was, there was a period of time where they gave him a period of time to calm down, and then they went to assess him.
Okay, and back to my original question, when Mr. Phillip was placed in the 4-point restraint, he did not calm down, did he? Until much later when they went to assess him, correct?
Object to form.
Right? He was continuing to yell and be agitated, and at some point he stopped doing that, and that's when the nurse went to assess him. That was what I believe happened in this case.
Okay. So it did not decrease his agitation when he was initially placed in 4-point restraint, correct?
Object to form.
When he was initially placed in there, he was still agitated for a period of time, yes.
Okay. Do you know the period of time from when Mr. Phillip was placed in the 4-point restraint until he calmed down and the medical personnel went to check on him? Do you know that period of time?
Based on best estimates, it was around 30 minutes or so.
Okay. And based on worst estimates, how long was it?
Object to form.
You know, based on what I think one of the officers thought it may have been longer, up to 60 minutes.
Okay. And as
And actually, best estimates, when I say best estimate, I would qualify that, meaning based on the information and putting it together, that is what seems to be the most accurate one, I should say, not the lowest. So I want to clarify that.
okay. But there are, and why do you choose the least amount of time as the most accurate?
Based on the testimony and of the nurses taking a 15-minute break, coming back for a small period of time, and then going to evaluate about 15 minutes later gets you to that point, versus the officer who was there with the patient or the officer that was there for a period of time wasn't really keeping a track based on some sort of time clock, versus the nurses were using. I went to break, he got there right as I got here, it was a 15-minute break, and then I checked him shortly thereafter, and that was seemed to have a more tight clock associated with it.
Okay. And what statement did you review from which nurse that indicated that it was 30 minutes?
I believe it was 15-minute break, and then after 15 minutes after getting back is when they went to assess him. So that's where I got the 30 minutes. And I
Okay,
think-
and I'm just wondering what nurse are you, what nurse's statement are you referencing?
I thought it was more than one, to be honest, but I think wasn't it a Kobe, but I have our code, I pronounce her name wrong, I apologize, a Koji, but I'd have to double check.
Okay. Now, isn't it true that Okoji also stated that she was not there when he arrived?
Check the form.
I believe that she said that she was not there, but she heard him arriving on a break or something along those lines. She was aware of his arrival, but was not physically there.
Okay. And if she was aware of her, according to the evidence that you have and you've reviewed, does it indicate the time that she became aware of his arrival in relation to the time that she took her break?
Check the form.
As I understood, it was roughly the time she was going on to break when she heard him coming in.
Okay. And you said that that information is found in from Nurse Okoji. Is that her deposition or is that her statement? Where are you getting this information from, Nurse Okoji?
I don't remember specifically what format I got it from, but that's what I recall is from.
Okay. And it looks like you, according to what you've reviewed, you've only reviewed her deposition. So is it safe to say it was her deposition testimony that you're relying on?
It may be the medical records as well. I'd have to review that.
Okay. So either the medical records or her deposition, correct?
Looking at the materials there, that would probably be correct. And I can't remember if another nurse said the same thing or not, but that's the one I think
Okay.
I remember.
Okay, and there's another deposition from that it looks like you reviewed from Nurse Rosa. Is that correct?
That's correct.
Okay. Do you know whether you reviewed the video or the transcripts for Nurse Rosa?
Transcripts.
Okay. So it's either in the deposition of Nurse Rosa or Nurse Okoji, or possibly the medical records that you determined that Nurse Okoji was, it was near the time she was taking her break that Mr. Phillip was brought into the medical clinic, correct?
Yeah, or if there was a review of a report that was put together, the death review or something like that may have been in there. I don't remember specifically where I saw the review of the timing.
Okay. But there's a lot of conflicts in the time, correct? Besides just the officer, correct?
Objection, form.
There are variations whenever you review something about different recalls, but yes.
Okay. And Dr. Vilke, I noticed that you were looking down to the side. Are you looking at your report?
I am, yeah, the list of materials for my report.
Okay. Are you aware that the time from when Mr. Phillip left his pod with the other inmates until CPR started was an hour and about 40 minutes?
Objection, form assumes facts not in evidence.
I'd have to re-review that. I remember it being a period of time, but I don't remember if it was an hour and 40 minutes.
Okay. Let me see if I can find what you reviewed that might have that information. Okay. Okay, and it looks like it could range from an hour and 35 minutes to an hour and 40 minutes. So it could be off by about 5 minutes. Were you aware of it taking at least an hour and 35 minutes from the time that Mr. Phillip left his cell with the guards until CPR was started on him.
Objection form.
That is familiar. I mean, there was a period of time he was in a holding cell up before he came down, and there was a period of time that he was in the area, and then the assessment, and then starting CPR. So it's potentially in range, maybe a little in that range, but that's about where it's probably at. Yeah.
Okay. Do you know how long he was in the holding cell?
I thought it was about half an hour, but I'd have to recheck records specifically.
Okay.
Maybe a little less.
Okay. And can you tell me, sorry. Dr. Vilk, can you tell me if you saw in any reports anywhere that you reviewed that, well, I'm going to back up and ask you another question first. Were you aware that Mr. Phillip was in the 4-point restraint when he was found unresponsive?
Objection form.
Yeah, when he got quiet, he was still in restraint, in this restraint position, I understand it.
The 4-point restraint, correct?
I believe all 4 extremities were restrained.
Okay.
Yes.
And when they had to remove the restraints in order to perform CPR, are you aware of that?
Objective form.
They did remove the restraints to perform as part of the process of that, assessing him and then starting CPR after that.
Mhm. Did you see anywhere in any report that when Mr. Phillip was found unresponsive, that he was in a 4-point restraint?
Objection form asked and answered.
I don't recall the specific, if it was that specific that when he was unresponsive, he was restrained at the time. I don't know if that's in a report or not. I don't recall.
Okay. And it's nowhere in the reports that he was in a 4-point restraint at the time that he was found unresponsive, correct?
Objection asked and answered.
There was no point. Say that again, please. I'm sorry.
There's no report anywhere that indicates that when Mr. Phillip was found unresponsive, that he was in a 4-point restraint, correct?
Objective form.
Again, I think they gave the answer before. I don't recall anything to that level of specificity, but it could be. I just don't recall anything specific.
Okay. And that includes your report, right?
Objection form.
My report does not, it doesn't say the 4 points were in position at the time that he was assessed for his unresponsiveness. I don't believe it's written in there, but I'd have to shackled to the gurney, that. It doesn't say he was unshackled, but I do report that he was shackled to the gurney, but I don't use the specific term that you're using as 4 points.
Okay. Is there another term that should be used?
And that says, yeah, she Nurse Akoji noted the pulse was faint and she had the shackles removed. So again, so I reflect on the idea of shackles replaced. I use the term shackles, but I didn't use the term 4-point restraints. That's what you're using. So it's referenced, but it's not referenced in this exact words that you're using.
Okay, what does shackled mean? Help me understand what shackled means from a medical standpoint.
Shackling is usually using forensic restraints, so usually cuffs to hold somebody in position rather than leather restraints or soft Velcro restraints. So I use the word shackle to typically reference forensic restraints.
So like iron restraints, correct?
Correct.
Okay, and does that, is there a way for a person to read your report and understand that Mr. Phillip was restrained by his ankles and his wrist at the time that he was found unresponsive?
Objection form.
Yeah, I don't think my report was reflective of all the specificities of his of the shackling, just that he was restrained to the gurney. I'd have to go through the rest of my report, but looking at my overview, I do reference him being shackled to the gurney, and that they unshackled him. Have to look a little further here though. Just to, let's see.
Dr. Can you tell me, and were you finished? I'm sorry.
I was referencing my article, my report here to make sure that I didn't. You're asking a specific question. I was seeing if I could quickly
Okay.
find something to answer it. But it certainly reference it. You know, the arms above the having arms restrained above the head in the gurney. And so I don't see where I actually were commenting on the leg being restrained, but that's typical because it really isn't going to impact my opinion because they're really sort of non. So yeah, I don't think it says specifically arms and legs were all shackled, but I was referencing more the arms.
Okay, and can you tell me what's, if you can, I don't even know if this is possible, but are there symptoms of an enlarged heart? And if so, can you tell us the symptoms that a person is experiencing having an enlarged heart?
So just purely an enlarged heart doesn't necessarily have symptoms unless you have heart failure or have something occurring with it. The enlarged heart, a lot of people don't even know they have until they have a cardiac event. But if you have an enlarged heart that creates congestive heart failure, then you might have symptoms that develop over time of shortness of breath or swollen legs or difficulty breathing, depending on the circumstances.
Okay. And I was reading about a let's see, it's a phenomenon. I don't know what way to describe this, or maybe a medical condition. I don't know, called agitated delirium. Have you heard of that?
Objection form.
Agitated delirium or excited delirium, yes.
Okay, it's the same thing. Okay, all right,
A lot of people reference them as being the same thing. Yes.
got it. Okay. And from the materials that you reviewed relating to Mr. Phillip, there is no indication that Mr. Phillip was actually trying to fight anybody, correct?
Objection form.
Yeah, I don't recall any specific, swinging or anything like that. He was, I think, biting at somebody's shoes is sort of odd behavior, but not necessarily fighting or throwing punches or kicking that
Okay.
directly at people. There may have been some kicking going on, but nothing that I recall being considered, interpreted as fighting.
And that includes, so, and there were, well, you didn't review the statements from the inmates, so I won't go into that. But there was no indication that he was in his cell trying to fight anybody, correct? Any of the other inmates, correct?
Objection form.
I don't recall any evidence that he was fighting other inmates.
Okay, Dr. Velk, have you, have you ever taught residents or medical professionals on alternatives to using restraints and when the use is necessary? That doesn't make sense, I'm sorry. Have you taught anybody on any alternatives to the use of restraints in the medical setting?
Objection 4.
I think we talked about this earlier, that, yeah, we've talked about the agitated patient and the use of restraints, and sort of trying to do verbal de-escalation, calming techniques, maybe seclusion, maybe offering medications. You know, some people you can, it depends on the level of agitation, you can say, hey, would you like a pill or a shot? You're kind of agitated, and sometimes they'll accept it, and then you can avoid the use of restraints altogether. So I've educated people on that concept that we talked about earlier.
Okay. Now, in the past, you have opined on the effects of placing weight on a person's back, correct?
The physiologic effects, yes.
All right, and that include a change in a person's ventilatory functions as being decreased, at least some, correct?
Objection form.
It's sort of, we've done numbers of studies looking at weights in the back and different amounts of weights. From a perspective of oxygen saturation and carbon dioxide levels, there are no changes. But if you measure ventilatory measurements using real sophisticated equipment, you can measure a small decrease in certain ventilatory parameters.
Okay. Do you know, are you aware that a patient like Mr. Phillip with congestive heart failure, one of the side effects is shortness of breath? Are you familiar with that side effect?
I would consider it a symptom of potentially decompensated congestive heart failure. People who are compensated don't necessarily have shortness of breath, depending on their.
Can you tell us the difference?
Meaning that if a person can have congestive heart failure, their heart doesn't work as well as it should. If you balance out their medications, their blood pressure medications, and their diuretics, and they maintain what they're supposed to be doing physically, they don't back up fluid into their lungs and have the symptoms of the congestion. But if they get fluid overloaded or not, or some other things happen, they potentially can have decompensated, which means the fluid's backing up, and that's when you would start to have symptoms of the shortness of breath.
Okay.
Not all persons with congestive heart failure actually have shortness of breath all the time.
Okay. And have you reviewed Mr. Phillip's medical records?
I have, yes.
Okay. And in fact, he actually did have the symptom of shortness of breath, correct?
At some points he did, yes. He was treated and then his symptoms improved. But yeah, that's a natural waxing and waning course for some people with congestive heart failure.
Okay. But you stated that he had shortness of breath and he improved?
At some point during his, if you look at his records, yes, he's had episodes where he's had fluids backed up or felt short of breath, and they get diuresed off with diuretics, and he gets better and the shortness of breath improves.
Okay. But it's not gone, correct?
Objection form.
Shortness of breath is a symptom, and it appears that there are times where his symptoms were resolved.
Okay. And did you notice that he went to the doctor on the 9th, which was about 5 days prior to this incident?
Objection form.
He was seen by the cardiologist, yes.
Mm-hmm. And there was some discussion about his shortness of breath and having fluid on his lung, correct?
They had discussed that previously. He, at the time though, was doing well, if I remember correctly, and there was no need to change medications because he was in a state of compensated heart failure at that time.
Yes. Okay. And do you remember the medications that were, that was indicated that Mr. Phillip was taking at the time?
Objection form.
Yeah, off the top of my head, I couldn't list them out for you, but he was on some blood pressure medications and some diuretics and some nitrates, I believe.
Okay. And one moment. Okay. And I'm going to pull up the medication if you just give me one moment. It's I wanted, while I'm pulling this up, can you tell me if you noticed that Mr. Phillip had an indication in his medical records of his conditions that he was suffering from? Did you notice the conditions that he were noted as on his problem list?
Objection form.
Oh, I don't recall the specifics of his problem list, but I remember him having the congestive heart failure and maybe hypertension as well. But I'd have to review that specifically.
Okay, and I think I have him here now. Okay. Are you familiar with a medication called Renexa?
Yes,
Okay, what is that medication used for?
it's a nitrate usually used for cardiac patients, often congestive heart failure type things.
Okay, and it helps with the symptom of shortness of breath, correct?
It can help. It's more preventative of it. So it's the idea is to help control the afterload of the heart so that you don't get the backload fluid. So to avoid the symptom of shortness of breath.
All right. Now it looks like on the last day that Mr. Phillip was in the custody of Harris County Jail, there were several, I'm sorry, my computer's loading. There were several indications of conditions that Mr. Phillip had listed as problems. And I think you reviewed that, but I'm going to try to pull it up for us.
Objective form. I don't think there was a question there.
No, I just need you guys hang tight for me while I'm pulling it up. Okay. All right. right, and I'm gonna go ahead and share the screen here, and you guys let me know if you can see it. Can everybody see it?
Looks like it's still loading.
Okay.
Yeah, I just have a black screen.
Me too.
I know. Okay, let me maybe use my other computer that was appointed me. Okay.
There you go.
All right. So here we see this.
What's the Bates number?
I don't know. I'll slide it up. I'm afraid to move it and it's freeze on us again. So, okay, 566.
Thank you. Thank you.
You're welcome. Okay, so you see this was signed on May 15th, 2016, correct? At 11:14.
Yes,
Okay, and it was indicated that this was entered by Carrie Rosa, correct?
correct.
And this is the electronic medical record, and that's why it has the electronically signed signature here, correct?
Correct.
I'm going to object that this mischaracterizes. That electronic signature goes for the entry above that UA. You need to go down to look at the electronic signature.
Okay, sure. I mean, I don't know if that is to be true. She testified that she entered this, so
I'm not saying she didn't enter it, but her electronic signature for the one you referenced is for the entry above it, not the one that you had highlighted.
oh, okay. So this would be Lindsay Fulkerson's note, correct? If it's the note for above, correct?
If that's the way it's set up there so that these signatures at the bottom of the page, it appears to be that would be for that note there.
Okay. So it was Dr. Fulkerson who entered this. I do see that there was a indication here of Carrie Rosa. I don't know what that means in this case, since we don't have anybody to interpret the records for us right now, but it's either Carrie Rosa or Dr. Lindsay Fulkerson that entered this note. And so do you see here where it says past medical history?
First, UA, let me object. Right now, we don't know who entered the note. Maybe, I mean, we don't know that it was Miss Rosa or Dr. Fulkerson.
Yeah, well, okay, it's we don't know, but we do know that this is Mr. Phillips' medical record. Who entered the note? We don't have an interpretation at this point. It would be one of the two, Rosa or Fulkerson, who entered this note, as indicated by the signatures on the inside of the note and at the beginning of the note and at the end of the note. At the beginning of the note, it shows Carrie Rosa, and at the end of the note, it shows Dr. Fulkerson.
And again, I'm just gonna object. You know, we don't, like you say, we don't know, we don't have anybody to interpret how these records work. We see these women's names on it, but we don't know whose note it is definitively.
Right, either one of the two.
No,
And-
I'm not gonna, no, that's what I'm objecting to. We don't know that it's one of the two. We don't know.
Okay. All right, well, if there's another person that could possibly enter this note, then
I mean, I don't know. I don't know. I don't think we know.
That's fine. Okay. Do you see where Mr. Phillip has this past medical history here?
Are you referring to the bottom of the page right now where it says past medical history written out?
Yes.
See that there, yes.
Okay. And you see where it says blood clots?
I see that, yes.
Okay.
I'm sorry to interrupt, but I am not able to see this note because the pictures of everybody is covering the note. Can the videographer remove our pictures from the screen?
Oh, you have to do,
If you hit escape, it'll take you out of the full screen view and you'll be able to see everything.
Okay, I apologize.
Oh, it's all good. No worries.
okay, so you do see where, what does CHF stand for?
Congestive heart failure.
Okay, and then there's COPD here also, correct?
That is listed there, yes.
Okay, and diabetes
Yes,
and HIV,
yes,
hypertension,
yes,
psychiatric disorder,
yes,
and seizure.
yes.
Okay. So since we don't know who wrote this note, between Carrie Rosa and Dr. Fulkerson, we don't know exactly why these past medical history indications are placed here, but we can see that they're placed here for the very first time in his report as a past medical history as it relates to blood clots, COPD, diabetes, HIV, psychiatric disorder, and seizure. Correct?
I'm gonna object to form.
I think the first part of your statement was that was one of the two people who authored it. Again, I think there was a question about who authored it.
Right.
And then your second part was, this is the first time in the record we see this. I'd have to go back through the record to see if it's been reported anywhere else. I seem to recall that there was reference to some of these diseases earlier on in the medical record, but I'd have to go through the record to confirm that.
All right. So I will let you do that, or we can do that. Can you look at this list of past medical history that's indicated on 5/15, 2016? Which ones you've recognized in the past?
Well, your question was, is this the first time it's been put in the medical record? And I have to, I recall them being in the medical record. Maybe it's from this note, but I'd have to go through the record to see if to answer your question, if it's the first time you see it in the medical record, that it's there. I seem to recall them being there previously, so I'd have to go and look.
Okay. Do you okay, so let's see if we can get to the beginning of the records. Well, you know what? Let me I'm going to go back to that list and ask you a quick question about that. How does one determine if a patient is suffering from blood clots? Is there a way to determine that?
Well, blood clots could be a history of a DVT. That could be from any period of time, or it could be blood clots to the lung, either of those. So that's usually what people reference to blood clots.
Okay.
And they're diagnosed by an ultrasound or CT scan or by history.
Okay, sorry about that. Okay. And what about COPD?
COPD is usually a diagnosis that's made either clinically, which sometimes is softer, versus through pulmonary function testing based on history of smoking and lung disease and chest x-ray changes and things like that.
Okay. And COPD causes difficulty in breathing, correct?
It can, yes.
All right. And what about diabetes? How is that determined that a patient is suffering from diabetes or has been diagnosed with diabetes?
Diagnosis is usually based on elevated blood glucose levels of certain levels, or elevated hemoglobin A1C levels that have been previously measured.
The testing?
That's usually, it's testing of it, correct.
Okay. And HIV, same thing, testing?
Blood testing typically, yes.
And hypertension?
Hypertension is usually diagnosed based on elevated blood pressures over time that ultimately they don't normalize, and so that's usually more of a vital sign check over time.
Okay. And what about a psychiatric disorder? Is that determined based on a well, tell me how that's determined. Sorry.
that's a very broad category. So as far as that goes, it's generalized. It can be any psychiatric disorder, which I think from substance abuse to anxiety to schizophrenia. So it's very non-specific, but that's usually diagnosed by somebody. It can be a medical professional, it can be a psychiatric professional, and then that's how it gets diagnosed.
Okay, and can you tell me if it can be based upon an event like this that Mr. Phillip exhibited with the altered mental state? Could it be determined based on this one day of event involving altered mental status and agitation, that a person has a psychiatric disorder?
Objective form.
An altered mental status, when typically presenting such as this, where there's a change in behavior, wouldn't usually be the only way of diagnosing a new psychiatric disorder. It's usually you have to have some additional history or something else going on there to typically get to that level. Just altered mental status wouldn't typically define that.
Okay, and as far as past history here, if there's not the tests that go along with these particular findings, how or why would a person find that this in fact is a past medical history? Is there?
Objective form. Sorry, I didn't mean to step on you.
No problem, no problem.
So your question is, how could this end up in the past medical history?
Without testing, or as you stated with the psychiatric disorder, an evaluation, or same with, I think, be without an evaluation. Is there another way that this past history could be indicated besides or outside of testing?
Well, often the past medical history is defined as such. It's from the past. So often it's what's reported by the patient or found in an old medical record or previous medical record, or reported by family members. So it's not necessarily tested at the time it's being placed in the chart, but it's a past or no medical history.
Okay. All right. So I am about finished.
I can hear the thunder
Yeah,
in
it's
the background.
serious over here. I'm just, I'm like, let me hurry up before the lights go out again. I don't know. Okay. Dr. Vilk, is it true that a patient who is experiencing agitation can also that can be manifest through increased heart rate?
Objection form.
And if you're saying, agitation can be associated with an increased heart rate. People who get agitated often have their heart rate go up. Can an isolated elevated heart rate cause agitation? I'm answering both questions. I'm not sure what you're asking there, but
Yeah, I got it backwards. I'm sorry.
yeah, an isolated elevated heart rate, wouldn't typically cause true agitation. It may make somebody uncomfortable, it may make them feel anxious, but not true agitation typically.
Okay. All right, I am going to go ahead and pass the witness.
Okay, Dr. Vilk, I just have one question for you, or maybe two questions. Early on in the deposition, excuse me, Ms. Lewis talked to you about what you reviewed, and if you have your report in front of you, that's on basically page 2 of your report, your expert report, correct?
Yes.
Tell me, did you review some medical records of Mr. Phillip that are not specifically listed here on your report?
Objection form.
I reviewed the jail medical records and the Harris Health medical records.
And so the jail records, are they specifically listed there on page 2?
They're not specifically listed there now.
But did you review the jail records?
Yes, they may have been part of one of the reports or something, but I did review them.
I have no more questions.
Okay.
I reserve all questions for time of trial.
Okay.
Are we done?
Well, did you review Mr. Phillips' medical records before he entered the jail from San Jacinto Medical Center?
And Vicinto, unless it was part of a report or review that had them in there as part of it, I don't recall them specifically.
Okay, and those would be the medical records that indicate that he's had prior heart attacks
Objection form.
and the stents.
I believe that's also in the cardiology report, but I don't remember those records specifically.
Okay, all right, thank you. I passed the witness.
Thank you.
Thank you, Dr. Vilk. Thank you,
Very
UA.
much.
Thank you, Suzanne.
Are we off the record?
Not yet, ma'am. So that concludes today's deposition. The time is 1:30 p.m. and we are now off the record.
So, Mr. Bignard,